Hi, welcome to DTV. My name is Millie Hughes. I'm an education outreach liaison at Doylestown Hospital. And today we have Dr. Todd Bromberg joining us. Hi, Dr. Bromberg. How are you?
Hi, Amelia. I'm great. Thank you so much for having me today.
Yeah, thanks for being here. So, why don't we start with just hearing a little bit about you, what you do, how long have you been doing it, things like that.
Sure. So I'm a pain management specialist, and what that means is that I treat conditions of chronic and acute pain, and we treat a number of different conditions. I am a neurologist, so I went through 4 years of training as a neurologist after medical school, and then I decided to specialize in interventional pain management, and I did that at the University of North Carolina for 1 year. And after fellowship, I moved to Doylestown, and that's where I started my practice. Actually, at the time, I joined a practice, which is one of the oldest pain management practices in the region, called Delaware Valley Pain and Spine Institute. And there we specialize in treating conditions of acute and chronic pain management.
Wow, that's amazing.
Thank you.
So, what exactly is a pain management physician? What are the types of things that you would do?
Yep, so good question. So many different treatments. Basically, we treat the entire body because it's possible that one could have pain anywhere in the body. Um, Anybody who is living has experienced pain to some extent. We treat pain that's severe and intractable. Um, Basically, my practice, we specialize in interventional pain management. And what that means is that we're treating conditions of the spine, the brain, the peripheral nerves, the joints. And this may include many different conditions. So people, for example, who have had surgery and haven't responded to the surgery, or they continue to have pain after the surgery, or people who have severe back pain, which afflicts so much of the population, or patients who have had major traumas like motor vehicle accidents. We will commonly see them. The most common conditions I would say that we treat are probably conditions of the spine. There's a very high percentage of people in this world who have degenerative disease of the spine. In fact, if you live long enough, anybody really above the age of 30 is going to have degeneration of the spine. And with that come some chronic pain disorders. And so probably the most common thing we see is disorders of the spine. As a neurologist, I also treat a lot of neurological conditions, whether it be peripheral neuropathy, which means damage to the very small nerve fibers, and even more so, chronic headache disorders I see a lot. I think what's different between myself and sort of a general neurologist is that my approach is an interventional approach, meaning I've been trained especially to treat pain through certain types of procedures and injections. And the idea there is that if we can block the pain receptor, and if we can do nerve blocks to block the pain, then potentially not only can we diagnose the issue, but we could also treat it as well. I will say that the most important thing I do is diagnose the problem, because without diagnosing the problem, we're going to have no idea how to treat it. And so diagnosis is most paramount in treating the patient in pain. Only when we've diagnosed the problem can we then treat it. Many of our procedures are actually designed not only to treat pain, but also to diagnose the problem. And sometimes it can take 2 or 3 types of injections before we really have a good understanding of what the pain generator is. And much of my job is for that purpose, to target the pain generator, figure out what it is, and hopefully treat it more permanently.
Wow. So, pain management physicians are kind of jacks of all trades. It sounds like you're doing a lot.
I like to think of it more like we're a quarterback, and especially in somebody who has had chronic pain and somebody who has had severe pain, really, I say oftentimes it takes a village to treat a patient in pain, and that is because pain can be so complex. The anatomy can be complex. The emotional component, what we call the affective component of pain, can be complicated, and there are so many different layers. I think this slide demonstrates it pretty well, where basically we have the patient who is at the center. It's the patient's pain that we are focusing on. But oftentimes it takes many different resources to treat that patient in pain. And so, for example, we have the physical therapist, we have the occupational therapist, we have sometimes the chiropractor, we have the acupuncturist. Sometimes if a patient has significant depression, as many patients with chronic pain have, we have a psychologist or psychiatrist involved. And what we do as pain management physicians is we serve as the quarterback. So we're sending patients to all of these different people in order to best treat the pain. But really, I I would be wrong to say that I'm the only component of this puzzle because really it takes many people to treat the patient in pain.
Yeah, like you said, takes a village, it sounds like. So tell us a little bit about your practice. You said it's the oldest pain management practice in the area?
So it's one of the oldest pain management practices in the region. My partner, Stephen Rosen, started it about 35 to 40 years ago now, and he's still practicing. He's a great innovator in the field. He started the practice out of Fox Chase Cancer Center where he worked at the time. And the treatment back then was primarily to treat patients with chronic cancer pain. Well, there are so many other people in pain that his practice at the time became an extension of what Fox Chase Cancer Center had to offer. And so with that, we privatized, we sort of went off on our own at that point. I joined the practice over a decade ago. We have 3 offices. One is in Trevose, one is in Doylestown, the Chalfont area, and then we have one in South Jersey also. We have 3 providers, so three physicians, I should say, 3 mid-levels, so PAs and nurse practitioners, and many, many incredible staff to help us treat our patients because, like I said, the pain population is one that requires a lot of resources, requires a lot of help, and so we are incredibly lucky just to have staff that's amazing. That includes nurses, that includes our mid-levels, that includes many medical assistants who have been with us for many years now.
Sure, that's a busy practice. Just because, like you said, so many people are experiencing chronic pain.
It's a busy practice. There's certainly no shortage of patients in chronic pain, unfortunately. I guess that's good for the practice. It's bad for society in general. But there are so many different sort of treatments that we have that we do need a lot of people. We do need a lot of resources. So, for example, in this list where it states what we do, it's a list of many of the different treatments. And I know the audience probably can't see this picture, and it's not designed for them to see it. It's designed to highlight the fact that we do many different treatments, many different procedures, many different medications. And knowing how to navigate all of those different treatments really does require a staff that's experienced, a staff that has been doing this for a long time. And as one of the sort of more experienced practices in the region, that's something that we're really proud of. In addition to that, not only are we treating patients, and not only have we done so for the past 3 to 4 decades, but my practice is very involved in research projects. So we feel that in order to provide the best care to patients and provide them with some of the newest and greatest therapies out there, we want to really push the envelope in terms of what we can do. And so not only are we learning new techniques and constantly sort of advancing our own practice, but we're also doing research studies. So we're involved with clinical studies on a national level where we're providing some of the most innovative treatments available for chronic pain management.
Wow. So with all that said about even just the prevalence of pain, tell us what the purpose of pain is in our bodies. Why do we experience pain?
Yeah, that's a really difficult question to answer. And it's strange even saying that because we all know what pain is. Everybody has experienced pain, but there are different features to pain. And it took actually a panel of expert physicians even to come up with a definition for pain. The definition they gave is somewhat boring. It's an unpleasant sensory and emotional experience associated with potential or actual tissue damage. Well, yeah, that's sort of like obvious. It's obvious that that would be the definition of pain, but it took a consensus panel to come up with it. And part of that is that there are so many different levels to pain. You have acute pain, you have chronic pain, you have emotional pain, you have physical pain. In its sort of most basic sense, the way I think about pain is it is an instinct. It's something that we all have built inside of ourselves for the purpose of survival. And we call that adaptive pain. Adaptive pain means that you touch that hot stove and automatically the reflex is to withdraw the finger because if you leave your arm on that hot stove, it's going to damage the tissue. And so in that purpose, pain is adaptive. Another example would be if somebody has appendicitis. Appendicitis, if left untreated, can potentially be deadly. If we didn't have that alarm system to know that something was wrong, patients typically wouldn't seek help. And so in that sense, pain is supposed to be adaptive. The problem is that when pain goes on for a really long time and when there's no rationale for that pain, we call it chronic pain, which is maladaptive. And maladaptive means that there's no real purpose of survival. It's there, it's plaguing the individual, And in that situation, I think of chronic pain as a disease. It's a disease state because it really serves no important purpose. And that's where I think pain becomes really complicated because at that point, no longer are we only talking about physical pain, but we're also talking about emotional pain. More than 50% of patients with chronic pain also have depression. And so there's this significant, what we call affective component to pain as well. Um, I like this quotation, which says, pain is inevitable, suffering is optional. And this really goes to the heart of what we do in pain management because everybody in this world is going to experience pain. What we do as pain management doctors is that we alleviate suffering. In fact, it's rare that I can completely get rid of somebody's chronic pain because the primary problem that's causing the pain typically will always be there. Unless there's a surgical correction, which oftentimes doesn't work 100%, pain will almost always be present when it's truly chronic. What we have the ability to do as pain management physicians is to alleviate suffering. I wish I knew who to quote in terms of having written this, but I've looked long and hard, and at this point, I'm just calling it anonymous. But I think this quote really resonates with my patient population.
That's great. So you mentioned earlier that there are many different treatments that you would prescribe or use as interventions with a patient. But if a patient sees you for chronic pain, will they be placed on an opioid medication? I think that's a common question that I hear people asking about chronic pain management.
Yeah, it's a really good question, and it's one that I get a lot. And I think it's one of like the great myths in terms of what I do. It used to happen a lot when I first came to Doylestown that patients and physicians would send me patients just because they wanted opioids. And it turns out the way that I see my position is to not put patients on opioids, but hopefully to prevent them from needing the opioids. And we will provide a lot of treatments in hopes of alleviating the pain and preventing sort of this cycle of medication need that patients sometimes fall into patterns of. I'm not saying that opioids are bad. I think when used correctly and when used responsibly, they are a very important tool in pain management. But there are consequences to opioids. There are consequences in terms of possible adverse effects. And we know that many opioids eventually stop working for chronic pain management. And so if we could identify again what the pain generator is, what we call the primary pain generator, we can attack that pain generator. We may be able to do a nerve block. We may be able to do a minimally invasive procedure or even a surgical procedure to block the pain and prevent the need for some of the high-dose opioid therapy. And I think it's the high-dose opioid therapy that has really become problematic in the past 1 to 2 decades. In fact, anybody who opens a newspaper or looks online almost on a daily basis, they will find that there are headlines showing this terrible opioid epidemic that we've all lived through for the past 20 to 30 years now. Unfortunately, the pandemic has actually only exacerbated this problem because in the past 3, 4, 5 years, we know that the number of opioid deaths has actually been on the increase. So in 2022, for example, there were about 100,000 opioid-related deaths in the United States, which is an incredible number. I mean, put that in context just in terms of how many deaths we've seen during the pandemic. The number is staggering. I mean, and not to take away from the pandemic, because those numbers are also very high. But when we deal with opioid deaths, it tends to be in a young, healthy patient population who are in the most productive years of their lives. And so it really is takes a great toll on society. And so we try to keep patients off of opioids because we don't want to oftentimes go down that slippery slope of having then to try to get them off the medication. But the opioids are a tool, and when used responsibly, they can be helpful.
Mm-hmm. And often people build up a tolerance to them, which I guess is another kind of consequence of using them. But do our bodies build up tolerance to any of the other treatments that you do as well? Is that a concern?
It is a concern. With any treatment that we provide, there's the potential for tolerance, which just really means in terms of opioids that you need more medication to have the same effect. So that's the idea of tolerance, that it takes more of that medication to have the same effect. And that happens in many different conditions, including blood pressure. Patients can develop tolerance to their blood pressure medication. They can develop tolerance to their antidepressants. Any medication can cause changes in the body, which leads to this idea of tolerance. And tolerance is one reason why patients with chronic pain will stop responding to opioids, because they need more and more of the medication to exert the same effect. There is another reason also, and I don't want to get too technical with this, but there's actually this idea that opioids can lead to the opposite effect. People take opioids thinking that they're going to get rid of the pain. And if you have a trauma, if you have surgery, if you have a major injury, yes, in the acute period of time, meaning the time immediately after the injury, that will happen. Opioids will work really well for that purpose. But when taken chronically, they lose their effect. And in fact, the brain will go through some physical and chemical changes that may actually make pain worse. We call that opioid-induced hyperalgesia. And this is a concept that's been recognized in the past decade. And it's for that reason that, number one, we only try to keep patients on low-dose opioids anymore. And number two, we try to use many different treatment options to prevent the need to increase the dose of the medication. There are other treatments that we do, I guess, where patients do develop tolerance. One of the groundbreaking treatments that I'm sure we'll talk about in a little while is something called spinal cord stimulation. It's groundbreaking in terms of the types of pains it can control, and even that can cause tolerance. So many of the interventions, many of the medications, many of the alternative treatments, even like acupuncture, can cause tolerance.
So tell us more about some of these groundbreaking advancements that you've seen in the past couple of years.
So I've been in practice, like I mentioned, for about a decade, and it's amazing how much the field has changed in just that short period of time. I would say one of the biggest movements in my field is that of minimally invasive treatments of the spine. And so in medicine in general, we've gone towards minimally invasive rather than maximally invasive types of treatments. And there's a number of reasons for that. Minimally invasive means less pain afterwards. It means less recovery time. Oftentimes it means less complications. And so if you think about cardiology, for example, if somebody had a blockage of their blood vessel, it used to happen that they had to open up the chest, do a major surgery in order to relieve the blockage. Nowadays, you can do that through minimally invasive cardiac catheterization. Not for all, but for some cases. Likewise, in the field of pain management, we're moving towards minimally invasive procedures in a similar way. And so one of the common conditions that occurs in individuals as they get older is what we call lumbar spinal stenosis. Lumbar spinal stenosis just really refers to the narrowing of the spinal canal. And when this happens, patients typically have a great difficulty walking. Oftentimes they require a walker, or they love the shopping cart, because by bending forward, they're able to decompress the spine a little bit. And sort of this is exemplified in this slide. On the left-hand side is a normal spine. On the right-hand side, this is the spine which is degenerated, and it exemplifies a case of spinal stenosis. Now, this is a cross-sectional view, meaning if we were to sort of take my body and chop it like this, we're looking at this from a bird's eye view. On the left, it may be hard to see, but in the front part of that picture, on the left-hand side is what we call the intervertebral disc, which is the shock absorber of the spine. Just behind that, there's a bunch of little dots which represent the spinal canal. And on the left-hand side, you can see that that spinal canal is nice and open, and it's basically round. In some pictures, it will look like a heart shape, but it's nice and open, it's round. So that's an example of where the spine is normal. And then right behind the spine is this pinkish tissue, which we call the ligamentum flavum. And in the normal spine, that should be really thin. Compare that to the picture on the right, which is an example of lumbar spinal stenosis. You can see in this picture that disc is bulging into the spinal canal. You can see that that ligament I mentioned, that pink ligament, which is really thin in the picture on the left, has now thickened quite considerably on that picture on the right. And what the disc bulge and what that thick ligament does is it squeezes the spine and causes physical narrowing of that structure. Now, it used to happen that the only way to decompress the spine was to do a major operation where the surgeon makes an incision in the spine. They do what's called a laminectomy, where they remove a little piece of the bone to decompress the spine. Well, it turns out we now have some minimally invasive approaches to treat this. And so there's a particular procedure called the mild procedure. And in the mild procedure, we put a small needle or small instrument into that pink ligament, and it gives us the ability to shave that ligament through an incision that's no bigger than just a few millimeters. Typically, it doesn't require even a single suture because it's such a small incision. And we have the ability to shave that ligament and restore its normalcy, basically. So no longer is it sort of like this thick, dense tissue, but we can restore it so it's no longer pressing on the spinal canal. This procedure is called a mild procedure, which stands for minimally invasive lumbar decompression. And to the point I made earlier about minimal recovery time, these patients typically require no recovery time. I usually tell them to lay low through the weekend, but then sort of just 2 or 3 days later, they're back to normal. And the treatments for mild to moderate stenosis can be quite effective. This is sort of a busy slide, and it may be difficult for the audience to see it, but on the right, it demonstrates the clinical studies that have shown that patients go from being able to walk on average 8 minutes to 56 minutes after this procedure. And it shows that patients can go on average from walking 246 feet to almost 4,000 feet after this procedure. Almost immediately after the procedure, the most common report from the patient is that they're able to walk to and from their mailbox with less difficulty, and they're able to shop with less pain. And that's because we've decompressed part of the structure that leads to that lumbar spinal stenosis.
That's amazing. What a testimony to just the advancements in medicine.
Yeah, and I will say that's one example. There's other examples also. And so one of the other common causes of low back pain is what we call SI joint dysfunction. Sacroiliac joint's the biggest joint in the body, but unlike almost every joint, it's not meant to move. Most joints are for the purpose of creating movement. So you could think of the shoulder, the elbow, the wrist. Those are all joints that move. The SI joint really doesn't move except during one point in a woman's life, and that's when the baby is going through the birth canal, because it's at that time when that joint is supposed to expand. Unfortunately, for a number of reasons, that joint can become unstable as we get older, and as it becomes unstable, it experiences excessive movement. It's that excessive movement which can commonly cause low back pain, and it can commonly cause even pain like sciatica radiating into the leg. It used to happen that the surgeon would have to make a really big incision. It was a major recovery, and they would put 3 large screws through the sacrum into the ilium, or I should say through the ilium into the sacrum, and it worked sometimes. We have another procedure that we do now, which is minimally invasive, where we're able to fuse that joint in a very similar way with an incision no longer than just sort of maybe 1 centimeter. And it's through that 1 centimeter incision that we can put the tools through which we inject a cadaver bone into the joint. By injecting the cadaver bone into the joint, it stabilizes it, it prevents it from being able to move, and over a period of about 3 to 6 months, the body's naturally going to develop its own bone around that fusion mass. In doing so, it's going to stabilize the joint and prevent the movement. That's one of the things I would say in the last couple years that has been a dramatic improvement in the field, because we can now do something through a minimally invasive approach that required in the past a major surgery. This sort of picture demonstrates the SI joint, and on the middle of the picture, the triangular shaped bone at the bottom of the spine is called the sacrum. That connects to the pelvic bone called the ilium. The joint space is denoted here by that red dot on the picture. And that red dot is basically where we put that little graft, that little implant. The little implant, by the way, is probably no bigger than my fingernail. So it really is very small, which means minimally invasive, minimal recovery, and patients typically have very little pain or discomfort after this procedure.
So you're talking about a lot of the advancements and things that are going well. Can you tell us about some of maybe a challenging case you've encountered? How did you approach that, and what did that look like? Were any of those advancements used?
Sure, I could probably tell you about many challenging cases. I guess one of the ones that I'll highlight I'm quite proud of, in part because it was in, I think, the Bucks County Courier Times, and so I could actually talk about this patient since she has sort of offered her story already to the public. But this is a very nice patient who I met probably about 5 years ago. She was injured at the age of 15 while riding her bike across the street. She was hit by a drunk driver. She sustained a major injury during which she fractured her pelvis. She fractured her leg. She was hospitalized for a prolonged period of time. And as a result of this injury, she had a lot of nerve damage. I met her about 25 years later when she was in her 40s, and at that time she had been living a life in pain. I will say not only a life in pain, but to speak to our earlier point, a life in suffering. And so she suffered with this nerve pain throughout her life, and she had tried many different treatments, including medications, physical therapy, various types of injections. And unfortunately, none of them provided her with much improvement. When I first met her, her pain scores were about a 9 out of 10 on that 10-point scale. And we ended up enrolling her in one of our studies. In this particular study, we use something called spinal cord stimulation. In spinal cord stimulation, we have the ability to use a pacemaker-like device to interrupt pain signals in the spine. By interrupting those pain impulses, if you can block them from reaching the brain, you can block their pain. And so we enrolled this patient in this particular study, and after just several days of having the therapy, she reported pain relief of about 95%. So she continues to have mild pain, but we've been able to get her off of the medications she was previously using. She's been able to return to work. She's been able to return to just about a completely normal life, and it's through a minimally invasive procedure. I will say this is one of the other groundbreaking therapies that we provide called spinal cord stimulation. Now, spinal cord stimulation has been around probably since like the 1970s. So it's a therapy that's been around for a while, much like pacemakers. And the company that first designed the spinal cord stimulator, they were also in the business of making pacemakers. And so there's a lot of overlap between the therapy. But the idea is that if we can block those impulses as they travel along in the spine from reaching those pain centers in the brain, we can essentially block the pain. That's the idea of spinal cord stimulation. The nice thing about spinal cord stimulation is before we ever do an implant, we do something called a trial. In a trial, we're able to put these very small wires into the spinal canal through needles, and we let patients try it. They test it for 5 days. If the trial provides dramatic improvement, then we would do an implant of the device about 3 or 4 weeks later. The implant itself is a minor outpatient surgical procedure. And I will say this is one of the advancements as well, because in the past, when we implanted these devices, they were really large, like the size of a hockey puck, even bigger. The devices have become so small. I mean, we've gone through like this battery revolution in everything that we do in this world. And the same is true for spinal cord stimulation. So I don't know if the audience can see this, but this is basically the battery now, which would require an incision maybe 3 centimeters long. We can place this through the incision, and it's small enough that patients typically don't see it. They can barely feel it. And this is basically the battery as well as the computer chip that is stimulating the spine to prevent the pain impulses. The other thing that has changed in this field, and I say this specifically because there are patients maybe who have had spinal cord stimulation in the past, and they said, oh, I tried that therapy, it was just like a TENS unit. Well, the old forms of it, it's true, they were like a TENS unit. Patients would feel like this stimulation, and it was that stimulation which would sort of overcome the pain, or was meant to sort of just like cover up the pain. Now we have ways of stimulating the spinal cord where the patients don't even feel it at all, but it's able to block those pain impulses. And so it's the blockade of those pain impulses, which is where spinal cord stimulation is most effective. And that's something that has really come about in the past 3, 4, 5 years. By using different waveforms, we can better block the pain signals.
Yeah, I love that story of that patient who had pain for so long and then, tried one of these innovations and it worked.
Oh, she is one of my greatest cheerleaders at this point, which is why she was so excited for this opportunity to speak to the Courier Times about it, because it provided her with so much improvement that she wanted to try to outreach and teach other patients about the therapy. She's now become sort of like an ambassador for the company that makes the spinal cord stimulator. So if we ever have a patient who needs education, oftentimes we'll connect her to this patient.
That's really cool. Well, I think we are at the end of our time for today, but thank you so much, Dr. Bromberg. The last thing I'll ask you is that if someone is interested in coming to your practice or to see you about pain management, how would they go about that? Is there a website or an email address that they should use?
Yes. So first of all, thank you for having me. This was I really enjoyed this conversation. I love what I do. I love being able to treat patients in acute or chronic pain. And so if there's somebody out there who needs our help, of course, we are happy to help. The best way to reach us is, I guess, one of 2 ways. They can always, if it's a new patient, they can submit a new patient form through our website. which is www.dvpsi.com, which stands for Delaware Valley Pain and Spine Institute. So that's one way they can reach out to us. The other way is just by the old-fashioned way of calling us. Our phone number is 215-489-9170. And those would be the easiest ways to reach out to us.
Great. Thank you so much. Thank you for joining us on DTV today.